So I hope I'm audible. So yesterday, before continuing, there was a question yesterday which was asked कि American society में, American Thyroid Society में, they do a radioiodine scan upfront. So the answer to it clearly remains that, see, any time a swelling of thyroid is going to come to you, irrespectively in the Indian settings, you are going to go for what is called as, you are always going to go for what is called as a USG initially, because it is the bedside investigation. जो भी तुम जहाँ भी जाओगे वो available रहने वाला है, उधर के उधर ही available रहने वाला है. So that is the reason you are first going to go for a USG. So USG, according to American Society, what did they say? That the scan is actually costing a lot, and उधर insurance claiming का problem रहता है. So most of the times what happens is these people settle around insurances also, because any insurance company for hyperthyroidism unnecessarily going out for a scan, they might trigger off some other problems. So that is the reason they have also included it that you can first go for USG and then you can plan for a scan. So it is depending on place to place, but point is eventually you have to go for a scan. So you need to plan a surgery, you need to plan a biopsy, you need to plan anything else, you have to go for a scan. So it doesn't matter what the guidelines say. Even in India, the first investigation for any thyroid swelling we do USG because it is readily available. रेडियो स्कैन करने के लिए पेशेंट को पहले उसके सब क्लियरेंस करना पड़ता है, उसके लिए 3-4 दिन जाते हैं, तो पेशेंट को तुम 4 दिन के लिए वैसे तो नहीं रखते. So any patient you are going to first, initially you are trying to go for USG and then you are going to go. That is what the American Thyroid Society says, and I hope it is clear that whatever you are saying yesterday, the doubt is very much clear. So now we are going to start off with what is called as a parathyroid gland. Parathyroid gland is very important. It is going to be the first step of entering in the endocrinology. Why? Because in endocrinology you will get to know that diagnosis of any endocrine condition. So the golden rule in endocrinology is diagnosis of any endocrine condition. The diagnosis is always and always going to be based on the biochemical parameters. So biochemically you are going to diagnose the patient, and the surgical treatment, the anatomical localization is where you are going to then go for, when you are going to go for imaging. In thyroid we saw that first you are going to do imaging, but इधर पहले imaging नहीं करने का, इधर पहले biochemical parameters करने के, and उसके बाद में you are going to diagnose the patient to have a endocrine condition, and then you are going to go for an imaging study, and then you are going to localize the disease, because we know that the endocrine glands are multiple. Adrenal gland है तो उसमें भी right adrenal, left adrenal, same goes for your parathyroid glands. So you have to localize, and localization comes later. So imaging is going to eventually follow. So first we are going to talk about some anatomy. We know that parathyroid glands are 4 in number. We already saw during the development that the superior parathyroids are formed from the 4. So superior parathyroids are formed from the 4th arch, and the inferior parathyroids are formed from the 3rd arch. Why? Because we know that 3rd arch also gives rise to thymus, and thymus is going to descend down into the mediastinum. So thymus, when it is going to descend down into the mediastinum, it is going to pull the inferior parathyroid glands below. So 3rd arch is going to give rise to inferior parathyroid glands. So inferior parathyroid is from the 3rd arch. So 4 glands, superior and inferior. There is one fundamental condition called as supernumerary gland. So what is supernumerary gland? So whenever there is going to be an additional gland, that is considered to be a supernumerary gland. And always remember, we have seen that the youngest child in the home is always notorious. Similarly, here the youngest child is going to be the inferior parathyroid gland. Because it is going to be inferior, it is going to be small, it is also going to be taken place from a small number. So that is the 3rd arch. So it is going to be the notorious child at the home. And that is the reason the supernumerary is also most common inside the thymus, which originates from the 3rd arch, which is going to be the inferior parathyroid gland. Same goes for ectopic parathyroid gland. So we are going to talk about ectopic parathyroid gland. Many times the parathyroid glands are going to be ectopic. हमने thyroid के module में भी देखा था कि the ectopic thyroid might be there in the lingual side, or it might be in the thyroglossal cyst. But here, the ectopic parathyroid gland, you know that there are 2 glands which are going to develop from different arches. So the 3rd arch is going to give rise to thymus, and thymus is in the anterior mediastinum. So the inferior parathyroid most commonly is seen in the anterior mediastinum. And superior parathyroid, हमें पता है कि superior 4 number 4 बड़ा, हम बड़े हैं, and that is the reason the superior is going to be relatively stable. So it is not going to go ectopic most of the times, but if the superior gland is going to go ectopic ever, if the superior gland is ever going to go ectopic, it is most commonly seen in the posterior mediastinum. It is going to be seen in the posterior mediastinum. तो ये कुछ MCQ के points है. The anterior mediastinum में कौन सी ectopic gland मिलेगी? Inferior parathyroid. Sir, posterior mediastinum में कौन सी ectopic gland मिलेगी? It is going to be the superior parathyroid. Why? Because the fourth pharyngeal are also give rise to the pharynx and the muscles of pharynx, and that is the reason we know that the esophagus and pharynx lie in the posterior side, and that is the reason why the superior parathyroid is going to be ectopically located in the superior into the posterior mediastinum. The size is going to be 50 milligrams and the usual dimension is 5 into 3 into 1 mm, so it is 0.5 centimeter. Color क्या है? तो color is going to be Portland brick color, so it is going to be a yellow brown color which distinguishes from a yellow fat. So always remember that parathyroid and lymph node. So how are you going to differentiate a fat or a parathyroid? So clinically when you are operating a patient, you think that this is going to be a parathyroid. Bedside investigation कैसे करने का? On the OT table, always remember that parathyroid and the lymph node is going to sink, and fat is going to float. So F for F, fat is going to float and the parathyroid is going to sink. So whenever you are going to take a container and you are going to put in even in a normal saline, you are going to put the gland if it is there, it is going to sink, but if it is going to be simple fat, it is going to be just the surrounding fat, then it is going to float. So it is very much important, but might not be true always. Sometimes if the gland is half cut, if the gland's weight is reduced, or if there is a small glandular tissue, then it might float. So it is not 100% true, but basic bedside investigation क्या है? The fat is going to float and the parathyroid is going to sink. Embryology क्या है? Superior gland from the fourth pharyngeal pouch with the ultimobranchial body, most consistent location, क्योंकि बड़ा है तो इसलिए stable है. Posterolateral to the thyroid, so always remember its location is always stable. And कहाँ है उसका location? It is going to be located at the ending of the inferior thyroid artery, जहाँ पे inferior thyroid artery end होने वाली है, उसके 1 centimeter above रहने वाला है, and it is going to be near the cricothyroid joint. Sir, cricothyroid joint का और एक significance आपने मुझे बताया था, वो मुझे याद है क्या? Yes, cricothyroid joint का और एक significance है that cricothyroid joint के पास में रहती है अपनी recurrent laryngeal nerve, and that is the reason why during the preservation of the gland, अगर हमें 3.5 gland surgery करनी है, we have to remove the 3.5 glands. So usually we are not going to spare the superior parathyroid gland. क्यों? क्योंकि अगर recurrence में मुझे operate करना पड़ा उस region में, तो recurrent laryngeal nerve is near the superior parathyroid glands. So whenever there is going to be a chance to you that you are going to remove the 3.5 glands, you are going to always remove both the superior glands. You are not going to keep them because their location is straight, you can trace them straight away, and also it is going to be near the nerve. So redo surgery के time पे जब fibrosis होगा तो it is going to be difficult for you to differentiate. Inferior parathyroid glands, it is from the third pharyngeal pouch and it is originating with the thymus, more variable position and can descend into the anterior mediastinum. So superior parathyroid कहाँ जाएगी? It can go into the posterior mediastinum. Ectopic is going to be in the posterior mediastinum. Blood supply देखोगे तो और 4 glands are supplied by the inferior thyroid artery, and that is the reason why in anatomical books they are going to say supra से कट के and infra से हट के. आज भी बीडी चौरसिया खोलोगे तो बोला है कि superior thyroid artery ligate near the gland and inferior thyroid artery away from the gland, but nowadays they don't ligate the inferior thyroid artery away from the gland, they are going to ligate it just near the gland because there are going to be numerary branches which are going to supply the inferior parathyroid gland. So rightly shown in the diagram, this is going to be the superior parathyroid, this is going to be the inferior parathyroid. Here you can see that where the inferior thyroid artery is going to end, उसके just 1 centimeter above रहने वाला है, and here there is going to be the location of the yes, you know that cricothyroid joint, and उसके पीछे अगर देखोगे तो this is the location of the recurrent laryngeal nerve. So that is very much important. इसलिए superior gland की recurrent surgery करते time there is high chances of damage to the recurrent laryngeal nerve. Very much important for you to know. Half life of PTH क्या है? 3.5 minutes. Sir, ये आप मुझे क्यों बता रहे हैं ये सब चीजें? Because it is very much important when you are going to manage the patient. This 3.5 minutes is important because after doing the surgery, after removing the parathyroid gland, the PTH level in the blood, the parathormone level in the blood is going to drop suddenly. So उसको less than 50% drop. So it is going to drop to less than 50% within the 10 minutes, and this protocol is called as Miami protocol. So क्या करने का? ऑन टेबल पेशेंट का पैराथायरॉइडेक्टमी होने के बाद में ब्लड सैंपल भेजने का, एंड इन दैट ब्लड सैंपल द पीटीएच लेवल्स आर गोइंग टू बी लेस देन 50% ऑफ द ओरिजिनल पीटीएच वैल्यू बिफोर द सर्जरी, एंड दैट इज कॉल्ड एज अ मायोमी प्रोटोकॉल बिकॉज इट्स हाफ लाइफ इज वेरी मच लेस. सर हाफ लाइफ लेस है, उसी के कारण पोस्ट सर्जरी इमीडिएटली पेशेंट को हाइपोकैल्सीमिया होगा. दिस इज द रीजन व्हाई आई टोल्ड यू दैट आफ्टर थायराइड सर्जरी इफ पैराथायराइड ग्लैंड्स आर सैक्रिफाइस्ड देन दैट इज द टाइम यू हैव टू गिव कैल्शियम सप्लीमेंटेशन जस्ट आफ्टर द सर्जरी. बट थायराइड का हाफ लाइफ ज्यादा रहता है, इसलिए थायराइड का सप्लीमेंटेशन नेक्स्ट डे से चालू करने का. So physiology has all the answers behind surgery, that is pretty much important, and anatomy has all the surgical landmarks which you have to know. So I hope it is very much crystal clear. PTH का फंक्शन देखोगे तो it is going to obviously increase the serum calcium by bone resorption, so it is going to increase the osteoclastic activity of the bone. It is going to increase the renal tubular calcium reabsorption and also going to increase vitamin D and gut calcium absorption. Sir, मेरे लिए सबसे important क्या है? This osteoclastic activity is very much important for me. Sir, why is it important for me? Always remember that this osteoclastic activity is going to be blocked by a drug which is called as bisphosphonates. So in a patient where you cannot operate, because we know that PTH is going to be high, it is going to cause bone resorption, उसके वजह से patient को pathological fractures होने वाले हैं. So to prevent those pathological fractures, to give medical management to the patient, I can give what is called as bisphosphonates to the patient. Palmidronate, zonidronate, ये drugs आपने सुने होंगे pharmacology में. So what are those drugs? These are the drugs which are going to inhibit the osteoclast activity, which is increased by PTH hormone. So it is very much important. I hope it is clear. So this is going to be the pharyngeal arch. So third pharyngeal arch से हमारे आने वाला है जो इधर उधर घूमने वाला है. So it is going to be your, the third pharyngeal arch is going to give rise to, yes, inferior parathyroids, and the fourth pharyngeal arch is going to give rise to superior parathyroids. So superior parathyroid is from the fourth arch. Phosphate भी important है because it is going to reduce the serum phosphate. It is going to reduce the serum phosphate. It is going to increase the excretion of serum phosphate. So it is very much important. It is very much important for you to know. So superior glands most consistent in position posterior near the inferior thyroid artery, near the cricothyroid joint, close to the recurrent laryngeal nerve entry point. And the second important thing is inferior glands are more variable, can be anywhere from the angle of mandible to the anterior mediastinum, because thymus is going to be there in the anterior mediastinum. All the four glands are received blood supply from the inferior thyroid artery, even the superior glands. तो ऐसे नहीं कि superior glands को supply आने वाला है superior thyroid artery से. No, the inferior thyroid artery is going to supply all the glands. And during surgery, remove the superior glands and keep the inferior glands, because the superior glands are going to be near the recurrent laryngeal nerve. So redo surgery के time problem नहीं आएगा. So it is very much important. So these are all the anatomical things which are related with the physiology, and we have studied about the physiology of the gland and the anatomy of the gland. Now coming down to the first disorder, which is going to be 85% cause of increased PTH. So any patient who is going to have increased PTH in the serum, 85% cause is going to be primary hyperparathyroidism. Primary hyperparathyroidism, it is the very common disease. Initially, this disease was not very much signified. Most of the patients had this disease, but when the symptoms came, when the patient had symptoms of hypercalcemia, that was the time when patient presented to the OPD, and when the patient was worked up, that was the time you got to know this patient has hyperparathyroidism. Nowadays what happens is yearly investigation. Sir, serum calcium हर साल जाता है, तो उसके वजह से हर साल में दिखता है इसका तो calcium बढ़ गया. क्यों बढ़ गया इसका calcium? Supplements चालू है नहीं है तो फिर वर्कअप करा लो. So nowadays, because of routine tests, the hyperparathyroidism incidence has increased, but it is because of the screening, or it is because of the routine investigation test. उसमें से भी primary hyperparathyroidism के अगर दो causes हमने पढ़े, या फिर rather you can say three causes, the most common cause is a solitary adenoma. तो एक ही gland अगर increase होने वाली है, so it is going to be a solitary adenoma. The second important thing which is going to be, it is again going to be 85%. The second important thing is going to be parathyroid hyperplasia. And the third important thing is going to be a carcinoma. Carcinoma is very much rare. We are going to talk about its management at the last. The most important thing is adenoma. Sir, क्यों adenoma important है? Because in cases of adenoma, it is a solitary swelling and you can go for excision. So excision के वास्ते, surgery के वास्ते, a patient to be cut under a surgery, it is the most important thing. इसलिए adenoma is very much important. So adenoma is around 85 to 90% of the cases. It is going to be most common and uniglandular disease. Sir, hyperplasia कहाँ दिखेगा? तो hyperplasia is associated with MEN syndrome. We already saw the components of MEN syndrome yesterday. MEN 1, pituitary adenoma, parathyroid hyperplasia, and patient will have pancreatic neoplasms. MEN 2 में हमने देखा MEN 2A, MEN 2B and familial variant of medullary cancer. तो उसमें सबसे बेकार कौन सा था? It was MEN 2B. We had to operate the child within 6 months of डायग्नोसिस. तो बच्चों आज जन्मा, उसके फैमिली में ऑलरेडी मेन सिंड्रोम्स पता है हमें चल रहे हैं. यू डू द डायग्नोसिस ऑफ द चाइल्ड विद MEN 2 सिंड्रोम, ही हैज दैट रेट म्यूटेशन, ही इज डायग्नोस्ड विद MEN 2B. Within 6 months of his borning, you are going to do a total thyroidectomy for the child to prevent medullary carcinoma of thyroid. Very much important for you to know. Many times there can be double adenoma, which can be 2 to 4%, and parathyroid carcinoma is less than 1%. And here what is important is you are going to check for parafibromin or PGP. So parafibromin is a protein. Parafibromin is a protein which is secreted by mature parafollicular cells. So parathyroid के जो mature cells है, these are going to secrete this. So it is a sign of maturity. तो अगर ये प्रोटीन मिसिंग रहेगा, वो पैराथायराइड ग्लैंड में अगर ये प्रोटीन मिसिंग रहेगा, तो देन इट इज कंसिडर्ड टू बी मैलिग्नेंसी. So which is that protein? It is going to be parafibromin, and known history is going to be a prior neck radiation. So agar prior neck radiation hai, so we saw that the patient is going to develop a disease. So it is very much important that you also know the risk factors. So what are the clinical features? How is the patient going to present to you? Patient is going to present to you with typical medicine given books. So it is going to be bones, stones, groans and psychiatric moans. So what is bones? We know that the patient is going to have subperiosteal resorption. Osteoclastic activity बढ़ेगी. PTH secrete ज़्यादा हो रहा है तो osteoclast ज़्यादा काम करेंगे. The calcium is going to enter from the bone into the blood, and that is the reason the bones are going to form brittle. It is also called as Brown's tumor, or it is also called as brittle bone disease. Brown's tumor, salt and pepper skull appearance, which is going to lead to pathological fractures. It is going to cause subperiosteal bone reception on the side of the phalanx. So हम अगर एक्सरे करेंगे हाथ का तो you are going to see the subperiosteal resorption. So PTH का अगर देखोगे तो it is very much frequently asked. These things are frequently asked in your NEET PG exams as well. Stones क्यों आएंगे? We know that whenever because of that there is going to be increased calcium excretion. हमने already देखा कि calcium अगर resorption बढ़ने वाला है, किडनी में calcium turnover बढ़ने वाला है, तो it can cause a lot of kidney stones. So renal stones can be formed. It can cause nephrocalcinosis, and patient might also have polydipsia and polyuria. Groans क्यों होंगे पेशेंट को? We know that because of hypercalcemia, the patient is going to develop what is called as constipation. The muscles are going to go into spasm. The smooth muscles, after going into the spasm, they are going to have constipation, nausea, vomiting, and calcium. Hypercalcemia is going to stimulate what is called as gastrin secretion, and it might also cause pancreatitis. We know that pancreatitis can be caused by hypercalcemia. It is rare. And also in pancreatitis there is hypocalcemia, because there is going to be the fat necrosis of the pancreas. The calcium is going to get deposited into the pancreas, and that is going to cause hypocalcemia. So pancreas ke patient mein the most important thing is monitoring of serum calcium levels. Why? Because we studied fat necrosis in pathology, and it is going to lead to calcification, and that calcium deposition in the pancreas is going to cause hypocalcemia. Moans क्यों होगा? Because calcium is going to increase, the patient might land up into depression, anxiety and cognitive dysfunction. So basically psychiatric manifestations. तो ये manifestations आने तक आजकल रुकते नहीं है लोग. Whenever the blood is given, whenever you are seeing that the patient is hypercalcemic, straight away evaluate करने का patient को कैसे करने का वो मैं बताने वाला हूँ अभी 2 minutes में. Cardiac anomalies. So we know that calcium is inversely proportional to calcium is inversely proportional to QT interval. So अगर तुम लोगों ने मेडिसिन में वो रूल पढ़ा होगा तो calcium is inversely proportional to QT interval. तो कैल्शियम अगर बढ़ेगा तो QT interval कम होगा. So that is what they have given. QT interval is reduced on the ECG, and that is the reason the patient might go into arrhythmias. And asymptomatic is the most common presentation which is detected incidentally. So this is the new line given in Bailey Love, that it is detected incidentally because of the increased routine screening. आजकल serum calcium naturally वो even when you are joining the jobs, when you are going for yearly investigations for fitness, calcium is done routinely. All the electrolytes, sodium, potassium, calcium, magnesium, phosphorus, these are given routinely. And that is the reason why these days it is picked up in the asymptomatic condition. So I hope it is clear to you. So what are going to be the clinical parameters? So the clinical parameters first is going to be elevated calcium. So अगर elevated calcium है तो patient को तुम evaluate करोगे. Whenever the patient has elevated calcium, the first thing you are going to do is you are going to evaluate the patient. Why is the patient having hypercalcemia? PTH might be elevated or inappropriately normal. So sometimes ideally what should happen whenever there is going to be hypercalcemia, so क्या होगा अगर मेरे बॉडी में 12 ml of नॉर्मली हमें पता है 7 to 11 mg अपना नॉर्मल वैल्यू है mg per dl. अगर मेरे ब्लड में 13 mg कैल्शियम है, आई एम ईटिंग कैल्शियम सप्लीमेंट्स, इफ माय कैल्शियम इज 13, व्हाट इज गोइंग टू हैपन? इट इज गोइंग टू सप्रेस द पीटीएच. तो नॉर्मली हाइपरकैल्सीमिया में पीटीएच के लेवल्स बिलो नॉर्मल होने चाहिए, बट इवन इन parathyroid adenoma you can find that the PTH levels are raised or they even might be normal, but that is called as disproportionately normal. क्योंकि अगर hypercalcemia है तो उसका compensatory mechanism should be hypo-PTH, but PTH is still normal. It means that something गड़बड़ है, तो इसका मतलब PTH is still high, so it can be considered as inappropriately normal. Serum phosphate अगर देखोगे तो it is low because it causes phosphaturia. So we have already seen that phosphate is going to increase from the kidneys. The kidneys are going to excrete the phosphate, and that is the reason why the patient is going to have phosphaturia. अगर bone turnover बढ़ेगा तो alkaline phosphatase भी बढ़ेगा. Alkaline phosphatase बढ़ेगा, it is because going to be increased bone turnover. So bone disease is already present. The patient might have pathological fractures. सर एक इंपॉर्टेंट टेस्ट करनी है 24 आवर्स यूरिन कैल्शियम। सर ये टेस्ट मैं क्यों करूं? अगर मुझे पता है पेशेंट को पीटीएच उसके बढ़ा हुआ है, पेशेंट को ऑलरेडी पेशेंट माइट हैव हाइपरकैल्सीमिया, बट व्हाई टू डू दिस टेस्ट? देयर इज अ रेयर कंडीशन कॉल्ड एज एफएचएच। व्हाट इज एफएचएच? एफएचएच इज फैमिलियल हाइपोकैल्सियूरिक हाइपरकैल्सीमिया। नॉर्मली किडनीज कैल्शियम एक्सक्रीट करती है, अगर कैल्शियम बढ़ गया तो नॉर्मल किडनी फंक्शन इज टू एक्सक्रीट द एक्सेस अमाउंट ऑफ कैल्शियम, बट व्हाट हैपेंस इन दिस डिसीज? द कैल्शियम एक्सक्रीटिंग रिसेप्टर विच इज प्रेजेंट इन द लूप ऑफ एनले, सो वी नो दैट लूप ऑफ एनले में कैल्शियम एक्सक्रीट होता है, कैल्शियम इज secreted inside the lumen, या फिर कैल्शियम might be reabsorbed. So DCT और loop of Henle में जो कैल्शियम रिसेप्टर्स रहते हैं, those are not functioning well, and that is the reason why the calcium is not excreted from the body. So it is a problem with the excretion. और इधर अगर तुम parathyroid gland निकालोगे तो then there is no use. The main problem is in the kidneys. So how to do it? You have to check the 24 hours urinary calcium and also compare with 24 hours urinary creatinine. So if that ratio is going to be less than 0.1, then it means that it is going to be FHH, or what is called as familial hypocalciuric hypocalcemia. But if you don't want to go into the details, just it is important that it is a differential diagnosis which is to be ruled out. मैंने अभी तक सब जो scans बोले हैं, those are just for the biochemical diagnosis of the disease. एक भी बार मैंने अभी तक USG का नाम नहीं निकाला, मैंने कुछ भी CT scan का नाम नहीं निकाला, मैंने कुछ भी PET scan का नाम नहीं निकाला. So only thing we are talking about is the biochemical parameters. So in endocrinology, in endocrine surgery, the most important thing is the biochemical parameters, nothing else. So after this, you are going to conclude the diagnosis. So हम लोगों ने क्या क्या किया अभी तक? So if you are going to do a flow chart, if you are going to make a flow chart, we are going to get to know that whenever the patient is going to have hypercalcemia अगर पेशेंट को आया तो सबसे पहले मैंने क्या किया, उसका पीटीएच लेवल्स देखा. पीटीएच लेवल्स अगर पेशेंट के इंक्रीज्ड या फिर नॉर्मल है तो इसका मतलब पेशेंट के बॉडी में कुछ गड़बड़ है. अगर इफ पीटीएच इज गोइंग टू बी लो, देन यू आर गोइंग टू सस्पेक्ट अदर एंडोक्राइन कॉजेस विच आर नॉन सर्जिकल. But here if PTH is normal or if it is increased, here what you are going to do, you are going to go for 24 hours urinary calcium to creatinine ratio. तो वो अगर if it is going to be less than 0.01, it means that the patient has FHH, familial hypocalciuric hypocalcemia. But if it is going to be more than that, more than 0.002, then you are going to conclude this patient to have, then you are going to primary hyperparathyroidism. So this is the time when you are going to label the patient as primary hyperparathyroid. Now primary hyperparathyroid मतलब क्या कि PTH बढ़ा है इसलिए कैल्शियम बढ़ा है. Simple as that. Calcium is not problematic. Problem is with the PTH, and why is PTH increased? It is because the problem is in the gland. तो अब ये होने के बाद में now I have to localize the disease. So how are you going to localize the disease? So localize करने के लिए दो tests हमें पता है. What are the two tests? It is going to be USG plus Sestamibi scan. सर अगर आपको याद है तो वी हैड ऑलरेडी टॉक्ड अबाउट सिस्टमिबी स्कैन व्हेन वी आर डिस्कसिंग जनरल सर्जरी, जिसमें हम लोगों ने न्यूक्लियर मेडिसिन के स्कैन्स के बारे में बात किया था. सो यूएसजी प्लस सिस्टमिबी स्कैन. सो यूएसजी प्लस सिस्टमिबी स्कैन इफ दे आर गोइंग टू बी कॉन्कॉर्डेंट. सर व्हाट इज कॉन्कॉर्डेंट? सर कॉन्कॉर्डेंट मतलब मैंने पहले यूएसजी किया तो यूएसजी इज इजी, इट इज अ बेड साइड इन्वेस्टिगेशन. यूएसजी करने के बाद में मुझे पता चला कि ओके द राइट सुपीरियर और द लेफ्ट सुपीरियर पैराथायरॉइड ग्लैंड इज हैविंग एन एडिनोमा. तो ये मुझे यूएसजी में पता चल गया, बट वी डोंट नो इफ दैट ग्लैंड इज फंक्शनिंग. तो उसका फंक्शनिंग चेक करने के लिए मैंने सिस्टमिबी स्कैन किया. In the Sestamibi scan, what did I do? After giving the Sestamibi का contrast, I checked out which gland is hyperfunctioning. तो उसमें भी आया सर लेफ्ट साइड की सुपीरियर ग्लैंड ही हाइपरफंक्शनिंग है. मतलब रेडियोलॉजिस्ट एंड न्यूक्लियर मेडिसिन पीपल वेर हैविंग द सेम ओपिनियन. सो इफ इट इज कॉन्कॉर्डेंट यू कैन गो फॉर व्हाट इज कॉल्ड एज अ फोकस्ड पैराथायरॉइडेक्टमी. But if the imaging is discordant, यहां तुम्हारे क्राइटेरिया बहुत सारे आते हैं. सर विच इज गोल्ड स्टैंडर्ड? अभी तक सब बुक्स में कुछ अलग अलग दिया है, बट इफ इट इज अ डिस्कॉर्डेंट इमेजिंग मतलब क्या? यूएसजी वाला बोल रहा है सर लेफ्ट सुपीरियर ग्लैंड में मुझे गड़बड़ लग रही है, बट न्यूक्लियर मेडिसिन पर्सन इज सेलिंग दैट नहीं सर मुझे तो राइट इंफीरियर में कुछ तो गड़बड़ लग रहा है, उधर का अपटेक में प्रॉब्लम है. सो देन डिस्कॉर्डेंट इमेजिंग अगर है तो यू हैव टू गो फॉर बायलैटरल नेक एक्सप्लोरेशन. But अगर मेरे पास में, if I get one beautiful actress, I won't take her name right now, but if a beautiful actress comes to my OPD and says, no, I don't want to have this big scar because it is a benign disorder, I don't want to get anything tested, it is a benign disorder, I don't want to have a big scar, I don't want to go for bilateral neck exploration, what is the thing which I can do? So whenever you are affording, whenever the patient is not having the scar, whenever she still wants a minimal invasive surgery or focused parathyroidectomy. Sir, what is focused parathyroidectomy? You are just going to place the incision where the parathyroid gland is, and with that small incision it might be even under the local anesthesia. So that is called as a focused parathyroidectomy, or it is also called as minimally invasive parathyroidectomy. So if a female actress whose neck is very much precious to her, she says that I don't want to have any scar, then there comes the special investigation, which is going to be selective venous sampling. You are going to again come across this selective venous sampling when we are going to study the adrenal glands. So what does the interventional radiologist do? They are going to insert the catheter from the femoral vein, and they are going to go into the neck, and they are going to take right-sided brachiocephalic trunk ka venous sample and left-sided. So whenever they are going to take both the samples, they are going to compare the PTH levels between both the samples. So right and left में अगर मुझे पता चल गया नहीं, the radiologist is telling right, the left gland is problem, then you can go for a left gland excision. And if it is saying that it is going to be the right gland which is the problematic, which is shown in the Sestamibi scan, then you can go for the right-sided minimally invasive parathyroidectomy. So I hope it is very much clear. So how are you going to manage the patient? Wherever you are going to manage the patient, so let's again get into the quick revision of how you are going to manage the patient with hypercalcemia. So whenever there is going to be hypercalcemia, you are going to check for what is called as the PTH levels. So PTH levels, if they are going to be normal or if they are going to be raised, it means that the PTH levels are relatively high despite the calcium being high. It means that the patient might be having hyperparathyroidism. Go for 24 hours urinary calcium creatinine ratio, and if it is going to be less than 0.01, label the patient as familial hypocalciuric hypercalcemia. But if it is going to be less than 0.02, then it means that PTH is causing that hypercalcemia. It means that the patient is having primary hyperparathyroidism. And if the patient is having primary hyperparathyroidism, now we know that there are 4 glands. उसमें से कौन सा gland में problem है, उसको करने के लिए you are going to go for localization studies. Localization studies is USG plus Sestamibi scan. Sestamibi scan is a nuclear scan. If both the scans tell the same gland of the same side, it means that it is a concordant imaging. You can straight away go for what is called as a focused parathyroidectomy or minimally invasive parathyroidectomy or the parathyroidectomy of that side with a small incision. Sir, but nahi, kuch gadbad hai. Nuclear medicine is telling the right-sided gland, the radiologist is saying left-sided gland in the USG, then you can go for what is called as bilateral neck exploration. So bilateral neck exploration can be done for the patient. But if there is going to be a beautiful actress who is going to come to you in the OPD and say that I don't want to have a neck exploration, then the interventional radiologist is going to come into the picture, and he is going to do what is called as, or he or she is going to do what is called as a selective venous sampling. And she is going to tell me, or he is going to tell me that whether the disease is going to be purely right-sided or left-sided, and I can proceed based on that approach. So I hope it is clear. If you just know these all things, that is more than enough. Short note, long answer, whatever is there, this is more than enough. If you know this much, it is more than enough, because here you can answer all the questions of NEET PG, you can answer all the questions of your UG or even somewhere in the PG exam. So this is what they are going to ask. Sir, other investigations. So we know that there is going to be the DEXA scan. So DEXA scan is going to tell you about the bone density. Orthopedic में हमने पढ़ा था. If the T score is going to be less than -2.5, indication of surgery. Even if the patient is asymptomatic, हाइपरकैल्सीमिया पेशेंट में दिखा एंड यू आर गोइंग टू गो डू अ डेक्सा स्कैन. सर डेक्सा स्कैन नॉर्मली इंडिया में करने लोगे तो पागल हो जाएंगे लोग बोलेंगे इससे अच्छा सर्जरी कर दो मेरा. सो यूजुअली वी आर नॉट फॉन्ड ऑफ बोन स्कैन्स अनलेस द पेशेंट इज हैविंग इंश्योरेंस और द पेशेंट इज गोइंग इनटू वेरी हाई सोशियो इकोनॉमिक स्ट्रेटा. बट इफ लोअर क्लास पेशेंट है, मिडिल क्लास पेशेंट है, नॉन अफोर्डिंग है, तो एटलीस्ट 2 investigations are important, Sestamibi scan and USG. So localization of adenoma is done, accumulates in the mitochondria and has 3 protocols. So I'm going to tell you about the Sestamibi scan. 2 मिनट में स्कैन के बारे में समझाने वाला हूँ. सर व्हाट इज द यूज ऑफ 4D CT? सो व्हेनेवर द Sestamibi scan is also not able to properly tell about the anatomy or the neck is already explored, there is going to be lot of scarring and fibrosis in the neck. So that is the time when you can give proper functioning of the gland, and it has the 4th dimension, which is the time. So what is the important? So whenever you are going to do the imaging during a contrast CT scan, there is going to be another factor which is time. So it is going to click the images based on different second times, and that is going to be very much important, better than MIBG or USG. So it is always important for you to know that it is always combined with MIBG or USG, MIBG and USG. So USG में neck, the adenoma is going to appear hypoechoic and the results are always going to be comparable to MIBG, but both the scans are very much important for localization. MRI करने का it is limited, cannot distinguish between posterior and superior glands, so MRI का ज़्यादा कुछ इसमें रोल नहीं है. And selective venous sampling rarely used for reoperative cases or with discordant imaging. So whenever I told you a beautiful actress, no scar on the neck, so that is the time when you are going to subject her for selective venous sampling. So I hope this protocol is very much clear to you. PET scan is emerging modality, but still the results are going to come out. It is not there in the meta-analysis, so it is not a gold standard. Might be the next edition say that we will go with the PET scan. False positives on Sestamibi. So concomitant, always remember, I told you yesterday that radioiodine ablation, the radioiodine ablation or the radioiodine uptake cannot be done by a Hurthal cell carcinoma of thyroid. So Hurthal cell carcinoma is not going to pick up the radioiodine, but it is going to pick up the Sestamibi. So it is very much important that you differentiate a parathyroid adenoma from a Hurthal cell cancer. तो उसमें लिए तुम क्या करोगे? थायराइड में घुसने वाले कुछ ट्रेसर मॉलिक्यूल्स ऐड करोगे. तो थायराइड के जो सेल में अंदर घुसेंगे तो वो मॉलिक्यूल्स को अगर हम लोगों ने उसका इमेजिंग अगर माइनस कर दिया तो वील गेट टू नो एक्चुअल पैराथायरॉइड ग्लैंड्स. सो आई एम गोइंग टू टेल यू द प्रोटोकॉल अबाउट सिस्टमिबी स्कैन थोड़ा सा डिटेल में जाके. माइट बी इंपॉर्टेंट इफ यू आर गोइंग टू स्किप इट ऑफ, इट इज अप टू यू, बट इट इज आई एम गोइंग टू टेल यू व्हेन आई एम गोइंग टू कंक्लूड इट. सो सबट्रैक्शन इमेजिंग कैन बी डन. Subtraction imaging can be done. So now talking about two words about the Sestamibi scan. So you can see this is the Sestamibi scan. सर एनाटॉमी कुछ भी नहीं दिख रहा है मुझे, बस इतना पता चल रहा है कि कुछ तो गले में अपटेक हो रहा है. सो सेम लाइक द रेडियो आयोडीन थायराइड स्कैन. So always remember what are you going to do. So the Sestamibi का प्रोटोकॉल ये है कि wherever there are going to be lot of mitochondria, उधर Sestamibi जाके बैठने वाला है. So Sestamibi is going to be taken up where the place where the maximum mitochondria are going to be present, and especially in the parathyroid and the thyroid cells. So early Sestamibi अगर तुम देखोगे तो early Sestamibi में thyroid भी उसके साथ में enhance हो रहा है, and later on if you are going to see the delayed images only one gland is getting enhanced. So this means that this is that adenoma. So anyway, any time when you are interpreting a scan, you are going to go for a delayed Sestamibi scan. So delayed Sestamibi scan. So delayed में ही तुम reporting करोगे. Never you are going to report in the अर्ली फेज. और अगर तुम्हें अर्ली फेज में रिपोर्ट करना है तो उसके साथ तुम क्या करोगे? यू आर गोइंग टू गिव अ थायराइड ट्रेसर. सो ये ट्रेसर जब तुम दोगे तो वो ट्रेसर अपना अपना लेवल माइनस करेगा, तो देन अगेन यू आर गोइंग टू गेट दिस पैराथायरॉइड ग्लैंड्स. सो एनी टाइम इंपॉर्टेंट इज दैट द Sestamibi scan is going to be accumulated wherever there is going to be lot of mitochondria, and these are going to be accumulated at the same time in the thyroid and the parathyroid cells in the early phase. But in the delayed phase, only it is the dye is going to be retained only and only in the thyroid, in the parathyroid gland. So whenever you are interpreting a result, whenever you are going to interpret the result of Sestamibi scan for parathyroid, always make sure that you are going to interpret in the delayed phase. I hope it is clear. So whenever the patient is going to come to you with a hypercalcemic crisis, so ideally तो मैंने at my level I'll refer it to medicine. But whenever you are going to be an intern or you are going to run your own hospital, you should know what is to be done. So we know that the QT interval is shortened, so patient might have arrhythmia. So arrhythmia's risk possible है. So what is the aggressive IV hydration? Simple logic है कि कैल्शियम को तुम स्टैट में कम नहीं कर सकते तो उसका पानी बढ़ाओ. So simple, whenever you are making शरबत, whenever you feel that अरे इसमें तो थोड़ा सा ज्यादा नींबू आ गया, तो it is looking like a sour शरबत. So what to do? Your mom is going to come and say अरे इसमें थोड़ा सा और एक काम कर, just put some amount of sugar and salt and add some more water. So you are going to add the water to dilute the actual lemon juice. So that is the same thing. कैल्शियम को तुम स्टैट में तो कम नहीं कर सकते, but when you are going to give IV hydration, the relative calcium will reduce. So give aggressive IV hydration, 500 ml per hour, target urine output more than 100 cc per hour. So that should be the target urine output. We saw that target urine output whenever the patient is going to be resuscitated, it should be more than 0.5 ml per kg per hour. Hammer it into your head. 0.5 ml per kg per hour, it should be the normal urine output. But when the patient is going to be in hypercalcemic crisis, the normal urine output for any patient should be at least 200 ml per hour, should be at least 100 ml per hour. Always remember, loop diuretics can be added. We know that the loop diuretics are also going to cause the calcium channels which are going to absorb the calcium back. वो channels को भी block करने वाले हैं, and that is the reason it is going to cause calciuria. So it can cause enhanced calcium secretion. Bisphosphonates. So bisphosphonates क्यों important है? Because bisphosphonates are going to prevent the osteoclast from breaking the bone. We know that the excess calcium might be coming from the bone as well. primary hyperparathyroidism में because of the raised hormone, the bone is getting stimulated, and that bone is going to stimulate the osteoclasts to bring the calcium back into the blood. So you are going to stop those cells by saying that abhi kuch kaam mat karo. So you can give IV zoledronic acid because these palmidronate are going to be oral drugs, and oral जब तुम दोगे तो oral का absorption and उसका action आने के लिए time ही नहीं अपने पास में. So whenever crisis, it takes 48 to 72 hours to act, but at least if you start IV, better late than never. You can give calcitonin nasal spray. So these are calcitonin nasal spray. So these are rapid onset sprays. So within 2 to 4 hours, they are going to cause calcium diversion into the bones. So you can give calcitonin nasal spray. Glucocorticoids इधर भी आ गए. Glucocorticoids कहाँ नहीं देखे हम लोगों ने. We saw glucocorticoids previously when we were also doing the thyroid. So glucocorticoids सब जगह पे आ रहे हैं. Whenever there is stress, there is glucocorticoids. It enhances the calcitonin action and useful in malignancy-related hypercalcemia. We also saw glucocorticoids in the brain tumor, the spinal cord tumor to reduce the edema. उधर भी glucocorticoids आए हुए थे. When we were also dealing with the thyroid storm, we talked about glucocorticoids. They are going to prevent the T4 to T3 conversion in the periphery. And dialysis is required if it is going to be a renal failure. And parathyroidectomy once the patient is medically stabilized. So parathyroidectomy आते आते यार hypercalcemia का patient parathyroidectomy no. First stabilize the patient, and after stabilizing the patient, then reassess, then do the imaging studies, and then you are going to go for what is called as parathyroidectomy. So what is the surgery indications? Obviously, if the patient is symptomatic, तो operate करना ही है. क्या symptoms हमने देखे? तो any symptoms of hypercalcemia, any symptoms of bones, moans, then psychiatric overtones. We also saw about the bones. ये सब भी चीजें हम लोगों ने देखी. We also saw that DEXA scan. अगर DEXA scan हम लोगों ने देखा, तो DEXA scan T score minus 2.5 से अगर ज़्यादा है, तो you are going to go for surgery. So we have already seen about the indications. We have also seen about the different investigations, and then we are already now talking about the surgery. So creatine clearance अगर पेशेंट का कम है, we know that when the creatine clearance is less of the patient might land up into the secondary hyperparathyroidism. मतलब क्या? We are going to talk about secondary hyperparathyroidism. What is the mechanism of secondary hyperparathyroidism? इधर ग्लैंड अपना ही काम करना चालू कर दी, कैल्शियम का कुछ कनेक्शन नहीं था. But whenever there is going to be a renal failure, vitamin D3 is going to be low, the calcium reabsorption from the kidneys might reduce, and that is the reason why the PTH is going to be stimulated. So already PTH stimulated है patient में because of the adenoma, and now because of the CKD on it, the cherry on the top, the patient is going to have more amount of hypercalcemia because of secondary hyperparathyroidism as well. So whenever the patient is in renal failure, the calcium is going to reduce and hyperparathyroidism is going to happen. That is called as secondary hyperparathyroidism. तो ये कंडीशन में पेशेंट को ऑलरेडी प्राइमरी है और उसके ऊपर सीकेडी अगर पेशेंट को बैठ गया तो पेशेंट को सेकेंडरी हाइपरपैराथायरॉइडिज्म भी होगा. तो you have added a fuel to the fire. So whenever you know that the patient's creatine clearance is low, tomorrow or day after tomorrow he might land up into dialysis, or the patient might go into the renal failure, he is going to develop the secondary hyperparathyroidism. Then that is the time you will first of all opt for surgery. Age less than 50 years, because we know that the patient has to live till 80 or 85. He should not have complications of calciums. DEXA score less than 2.5, serum calcium more than 1 mg per dl above the upper limit of normal. So India mein level is going to be 7 to 11. So 7 to 11 is the normal range. So if it is even going to be 12, that is the sign of indication. And 24 urinary calcium is more than 400 mg per day with nephrolithiasis risk. We have seen that there is a condition called as FHH. What is FHH? It is going to be familial hypocalciuric hypercalcemia. So kidneys are not secreting the calcium properly. So anyway you are going to go for 24 hours urinary calcium for the patient. Very much important. Sir, surgery क्या क्या करोगे? So minimal invasive parathyroidectomy or focused parathyroidectomy. Single gland disease is confirmed by concordant imaging. तो मैंने हम लोगों ने बोला MIBG plus USG करना है, and then you can go for a targeted excision. So wherever the gland is, just put a small incision and you are going to excise the gland. Bilateral neck exploration indicated if discordant imaging, or if the patient is already having MEN syndrome. तो MEN syndrome अगर already patient को है, it means that the patient has hyperplasia only. MEN syndrome में hyperplasia ही दिखता है, even if the features are suggestive of adenoma, but in MEN syndrome, irrespectively, you will have to take off all the glands. We are going to talk about it in this short time. If it is a familial disease or if it is a reoperative case, it's very much important. Intraoperative monitoring. So ये जो मैंने आपको पहले ही बताया था, this is going to be the Miami criteria. After you are going to remove the diseased gland, you are going to send the PTH after 5 minutes. So normally the PTH should drop from 50% to the baseline and into the normal range within 10 minutes of the excision. So that is the time when the cure is going to be confirmed. So when you are going to send that tumor, into the histopathology bottle, after 5 minutes or maybe 10 minutes, send the blood sample to the histopathology to the pathology lab and your biochemistry lab and tell them that मुझे अभी PTH के values बताओ, and तब तक you are going to sit for the surgery. So whenever you are going to go for a focused parathyroidectomy and whenever you are going to remove a single gland only, after removing the gland, after sending the sample for your PTH assays, you are going to wait there for until the report comes. नहीं तो अगर रिपोर्ट में कुछ गड़बड़ आ गया तो देन द पेशेंट विल रिक्वायर अ सेकंड सर्जरी विच इज गोइंग टू बी इवन ड्रेडफुल. तो उसी टेबल पे यू हैव टू टेक द डिसीजन दैट यू आर गोइंग टू गो फॉर एक्सप्लोरेशन और इवन द वन ग्लैंड रिमूवल इज गोइंग टू सफाइस. Sometimes subtotal parathyroidectomy can be done. 3.5 glands are removed and leave half the gland in the C2 as well. And well vascularized inferior parathyroid gland is favored. Why? Because we talked that superior parathyroid gland is always near the recurrent laryngeal nerve, and whenever there is going to be a resurgery, that is the time when the fibrosis is going to be there and very difficult for a dissection of superior parathyroid gland and recurrent laryngeal nerve injury might happen. Total parathyroidectomy plus autotransplantation. So whenever there is going to be a MEN syndrome, you are going to go for all the 4 glands excision at the same time and you are going to implant it into the brachioradialis muscle. Sir, ऐसे क्यों करने का, brachioradialis muscle से क्यों लेने का? Simple logic, अगर तुम्हें उसका हाइपर पीटीएच अगर उसको बाद में भी अगर उसको वो छोटे से ग्लैंड से भी ट्यूमर निकला या फिर वो छोटी सी ग्लैंड भी हाइपर सिक्रीट करने लगी, तो यू कैन सिंपली टेक द वेनस सैंपल फ्रॉम दैट आर्म एंड यू कैन चेक फॉर द लेवल्स. नेक में कहां से सैंपलिंग करोगे? नेक में हमेशा कहां से सैंपलिंग करोगे? राइट एंड लेफ्ट आईजेवी का. सो इट्स ऑलवेज बेटर दैट यू आर गोइंग टू री-इम्प्लांट इट इन द आर्म व्हेनेवर यू नो दैट देयर इज गोइंग टू बी रिस्क ऑफ मैलिग्नेंसी, रिस्क ऑफ रिकरेंस, व्हेनेवर देयर इज रिस्क ऑफ hyperplasia, when there is a syndromic or familial inheritance, then that is the time when you are going to remove all the 4 glands and you are going to implant one gland in the brachioradialis muscle. पहले वो sternocleidomastoid में करते थे, but then they got to know that again neck में incision देना is very bad, so they've now implanted in the brachioradialis muscle. So primary PHPT confirmed, USG plus Sestamibi scan, concordant imaging, both are there to focused approach and confirm with Miami criteria. But discordant imaging here, disagreement between the imaging modalities. You can go for 4D CT for further localization, but 4D CT से भी नहीं. The best important thing you can go for is going to go for the bilateral neck exploration and remove the 4 glands. It is very much important, and you can plant the half gland in the brachioradialis muscle. And intraoperative Miami criteria is important. More than 50% reduction plus normal range is equal to cure. So that is the time when you can say that the surgery is successful. I hope it is clear. So what are the post-operative issues? Thyroid में हमने देखा hypocalcemia हो सकता है because PTH के values are going to be only for 3 to 5 minutes. The patient might land up into hypocalcemia soon after the surgery. So here क्या होने वाला है? Persistent calcium might be elevated within the 6 weeks, and it means that your surgery has failed. So surgery fail हुआ मतलब क्या हुआ? Your localization studies are not adequate and the patient is going to suffer the loss. The patient is still going to have the glandular disease and the patient is going to develop the symptoms of hyperparathyroidism again. That is the persistent disease. What is the recurrent disease? Recurrent disease मतलब क्या कि 6 months तक patient was absolutely fit and fine, but 6 months के बाद में patient को वापस से और एक gland hyper function करने लगी या फिर adenoma आया, so it is going to be a recurrent disease. So what is persistence? Persistence मतलब you have missed it at the time of operation. Recurrence मतलब patient को वापस से वो disease हो गया after 6 months, so it is a recurrent disease. Same thing we are going to talk about in the gallstones as well. So recurrent gallstones and persistent choledocholithiasis. So what are those differences? The gallbladder के time पे we are going to discuss. So what is hungry bone syndrome? So घर में बच्चा देखा है, टीवी देखना रहता है, बहुत बार टीवी देखना रहता है, but mother is persistently switching the TV off. Now what happens? Mother suddenly goes because she gets a call and she is on the emergency and so she goes. So बच्चू क्या करेगा? Suddenly remote लेगा और जो भी दिखे वो सब देखने लगेगा. Initially he might have seen maybe for 15 minutes, 20 minutes and then switched off the TV. So he might be happy with that. But mother had stopped him for almost 4 hours. So now his happiness was still not able to measure, so उसने वो जो टीवी चालू कर दिया, 8 घंटे टीवी देख लिया. बोन्स का भी वैसे ही होता है. persistent बोन को जब तुम the bones are going to secrete the calcium into the blood, persistently the osteoclastic activity is going to be high. Suddenly osteoclast का simulation बंद हो गया. The bones are going to be like, yes, now our destruction has stopped, now let the calcium come in. So अचानक से सब calcium bone में जाएगा and that is going to cause severe hypocalcemia, that is called as a hungry bone syndrome. So even after you are going to remove the parathyroid glands, always monitor the calcium level, because the bone is going to rapidly mineralize and prolonged hyperparathyroidism की वजह से ही होने वाला है. Treat with IV calcium gluconate and magnesium, very much important for you to know. And permanent hypoparathyroidism कुछ patients में हो सकता है. If you are going to remove all the 4 glands, the patient might have permanent hypoparathyroidism, so उसको lifelong PTH supplementation life में लगने वाला है. So he might require the PTH supplementation for lifelong, very much important for you to know. So few drugs which are going to be useful for treating adjunct management के लिए, bisphosphonates हमने बात किया, it is going to be zoledronic acid. Why? Because it is going to be given IV. Sir oral drugs तो endocrinologist या फिर MD medicine के लोग देखेंगे, हमारा काम है बस ये देखना. So it is going to give bone protection. It does not treat the cause, but it reduces the risk fractures. But alone it is not going to be insufficient for hypercalcemia, because problem is with the hyperparathyroidism. It is going to be with the parathormone. तो उसमें प्रॉब्लम है. तो what is the use of giving this? It is just going to act as an adjunct. Sir, denosumab, so it is going to be an antibody. It is going to be an antibody. So normally what happens is, this is going to be the osteoclast cell. So ये osteoclast cell है, उसके ऊपर क्या होता है, rank ligand करके एक receptor रहता है. So this rank ligand जो रहता है, तो it is going to activate the osteoclast cell. So what happens is, bisphosphonates are going to directly go and block this cell. So bisphosphonates are going to act at this level. तो छोटे लेवल पे, कामगार लेवल पे काम हो रहा है. बट मोस्ट ऑफ द टाइम्स क्या होगा, अगर ये सुनना ही नहीं रहा है, ये सुन ही नहीं रहा है अपना, तो हम जाके बॉस से बात करेंगे, बोलेंगे बॉस को भाई काम बंद कर अपना, चुपचाप बंद कर, इट इज वेरी मच इसेंशियल. सो रैंक लाइगैंड को ही हम लोग इनिबिट करेंगे. सो डेनोजुमैब इज गोइंग टू इनिबिट द रैंक लाइगैंड. सो इट इज अ रैंक लाइगैंड इनिबिटर. इट इज गोइंग टू बी यूज्ड इफ द bisphosphonates are intolerant. So that was the trial which was given. So it is a denosina trial. So denosina trial, कुछ trials important रहते हैं, वो मैंने इधर नाम include किए. So denosina trial was very important, where they found out that if the bisphosphonates are not acting, a patient is not ready for surgery, the patient is not fit for surgery, so you need to give the palliative care to the patient with bisphosphonates. वो भी काम नहीं कर रहा है, तो you can go for denosumab. It is going to be 6 monthly subcutaneous injection. So एक subcutaneous injection दिया, तो patient को 6 monthly वापस कुछ करने का जरूरत नहीं है. Cinacalcate, it is a calcimimetic. So it is going to activate the calcium sensing receptor. It is going to reduce the PTH and might be used in the inoperable case. So cinacalcate can be used whenever the patient is going to have the palliative care, not fit for surgery. Hormone replacement therapy also can be done, because it is going to increase the bone mineral density. We have seen that postmenopausal patients might have osteoporosis and hot flushes. So उसके लिए भी हम लोग क्या देते हैं patients को, और HRT के बारे में हम सोच सकते हैं, but it is going to increase the risk of breast cancer. So it is going to have the increased risk of breast cancer. And always remember that selective estrogen receptor modulators are now used, and roloxifene is the new drug which is going to have less vascular risk, because these patients might land up into what is called as DVT, deep vein thrombosis. And thymectomy is also done with MEN1 syndrome. Concurrent thymectomy during parathyroidectomy reduces the supernumerary gland risk. So मैंने already बोला कि inferior is going to be the most notorious gland, and the supernumerary glands, मतलब जब glands are going to be more than 4, they are going to be present in the thymus. So whenever you are going to operate for a MEN syndrome, anytime you are going to operate for the MEN syndrome, they say that you can go for that thymus gland excision also, because the supernumerary glands might be present in the thymus as well. So you can go for what is called as a thymectomy. So now coming down to secondary hyperparathyroidism, chronic linear failure, reduced phosphate excretion, it causes hyperphosphatemia. FGF23, अभी अगर तुम medicine पढ़ रहे होंगे specifically from all the high platforms, so FGF23 is secreted by the bones, and this is going to be an indicator of phosphate retention. So whenever the phosphate is going to be retained, the calcium is going to be reduced and sustained PTH stimulation. So अभी हमने बात किया कि kidneys are not able to preserve the calcium because the phosphate is going to accumulate in the body. Phosphate is also going to be accumulating in the body, and that phosphate is going to stimulate, which is called as FGF23. So FGF23 is going to increase, and FGF23 is going to reduce the calcium in the blood, and that is the reason the patient is going to have persistently hyperparathyroidism. The calcium is going to be low, and hence the PTH is going to be stimulated. Also, the vitamin D is going to reduce, and that is the reason the calcium of the gut cannot absorb more amount of calcium, hence it is going to further lower down the calcium levels, and results hypocalcemia with elevated PTH. And it is important to distinguish between the primary cause, where always remember that calcium is going to be high. So secondary में calcium always is reduced, and calcium reduce होने के कारण पैराथायरॉइड को ज्यादा काम करना पड़ रहा है. तो उसमें पैराथायरॉइडेक्टमी करके कोई पॉइंट है क्या? नो, बिकॉज पैराथायरॉइड्स नॉर्मल है उसमें, बट कैल्शियम कम है, इसलिए पेशेंट में प्रॉब्लम हो रहा है. सो गिव फॉस्फेट बाइंडर्स. प्रॉब्लम कहां से आया? फॉस्फेट रिटेन हुआ ब्लड में, फॉस्फेट ने एक्टिवेट किया FGF23. सो PO4 accumulate हुआ, it activated FGF23 and it is going to reduce the calcium. तो ये सब अगर बोलोगे तो फॉस्फेट को ही बाइंड करो, तो विलन को ही तुम लोग अगर मार दोगे, विलन के बॉस को ही मार दोगे, तो ना रहेगा बास, ना बजेगी बांसुरी. सो कैल्शियम कार्बोनेट, सिवालामिलर, सो सिवालामिलर is going to reduce the hyperphosphatemia, so it is going to bind the phosphate and reduce the phosphate levels. Vitamin D अगर दोगे तो naturally it is going to increase the calcium levels in the blood, increase the gut absorption of the calcium, and it is going to bypass the 1-alpha hydroxylase mechanism. We know that kidney has 1-alpha hydroxylase which is going to convert the vitamin D2 into D3. The active form is going to be converted by the kidneys, but kidney का 1-alpha hydroxylase working ही नहीं है, so that is the reason you are going to directly supplement the patient with active vitamin D3 which is calcitriol देने का. Cinacalcet is a calcimimetic effused for diffuse hyperplasia. तो whenever the patient is going to land up into what is called as a tertiary hyperparathyroidism. सर tertiary क्या होता है? सर secondary में glands hyperfunction कर रहे same as multinodular goiter. multinodular goiter में nodules बन रहे एक point के बाद में nodules बोलेंगे हम किसी का नहीं सुन रहे, हम अपने आप से hyperfunctioning चालू कर रहे हैं. So they start to become hyperfunctioning. Similarly the glands are getting hyperplasia because of reduced calcium. एक पॉइंट पे सडनली दे आर गोइंग टू स्टार्ट एक्टिंग ऑन देयर ओन, दैट इज गोइंग टू कॉल्ड एज टर्शियरी हाइपरपैराथायरॉइडिज्म. तो उधर हम लोगों को पता है कि बिकॉज द ग्लैंड्स आर गोइंग टू इंक्रीज, यू कैन गिव व्हाट इज कॉल्ड एज अ सिनाकैल्सेट which is going to again be a calcium modulator. We have already seen about the cinacalcet. It is going to activate the calcium sensing receptor on the parathyroid gland and it is going to reduce the PTH levels. So we have already seen all those things. रीनल ट्रांसप्लांट में तो डेफिनेटिव ट्रीटमेंट है. रीनल ट्रांसप्लांट अगर तुम करोगे तो नेचुरली सब मेटाबॉलिज्म नॉर्मल होने वाला है. द पेशेंट्स हाइपरकैल्सीमिया इज आल्सो गोइंग टू, द हाइपोकैल्सीमिया इज गोइंग टू बी करेक्टेड एंड हाइपर पीटीएच इज आल्सो गोइंग टू रिड्यूस. सो इट इज वेरी मच इंपॉर्टेंट. सर्जिकल मैनेजमेंट में क्या है? सो व्हेनेवर यू आर गोइंग टू गो फॉर सर्जरी टू दिस पेशेंट, कब सर्जरी करना है इस पेशेंट में? सो व्हेनेवर देयर इज गोइंग टू बी फेलियर ऑफ मेडिकल मैनेजमेंट. तो ये सब देखे, फॉस्फेट बाइंडर्स दिया, डायलिसिस किया, रीनल ट्रांसप्लांट के लिए भी प्लान किया, ये सब होने के बाद भी अगर कुछ नहीं हो रहा है, इसका मतलब द पैराथायरॉइड ग्लैंड्स आर माइट बी हाइपर फंक्शनिंग. सो हियर what you are going to do, you are going to do a ratio which is called as calcium to phosphate ratio. So whenever you are going to multiply the calcium levels multiplied by the phosphate levels, if this ratio is going to be more than 55, it means that the patient has a risk of calciphylaxis. हम लोगों ने ऑलरेडी क्यूटेनियस लीजन्स में देखा था पेशेंट के कि पेशेंट इज गोइंग टू हैव मल्टीपल क्रस्टिंग लीजन्स, मल्टीपल, जैसे हम लोग देखते ना वुंड पे जैसे स्कैब होता है, वैसे मल्टीपल स्कैब लीजन्स ऑल ओवर द बॉडी. इट इज नॉट सेल्यूलाइटिस, इट इज नॉट एन इन्फेक्शन, इट इज नॉट गोइंग टू बी ट्रॉमा, इट इज गोइंग टू बी calciphylaxis. There are going to be multiple patches over the skin. And how to protect that calciphylaxis? The calcium into phosphate ratio is always going to be more than 55. So whenever it is going to be more than 55, it is going to increase the calciphylaxis risk. It is going to cause calcification of the blood vessels and also going to cause arteriolosclerosis, and patient might have MI also. So that time you can go for what is called as a parathyroidectomy. And never remove all the 4 glands, it is going to cause permanent hypoparathyroidism. So here also you are going to go for 3.5 gland resection. So secondary hyperparathyroidism मध्ये 3.5 ग्लैंड रिसेक्शन करने का. कौन सी ग्लैंड रखने की? इंफीरियर ग्लैंड रखने की. क्यों? क्योंकि इट इज अवे फ्रॉम द इंफीरियर लैरिंजियल नर्व. सुपीरियर ग्लैंड्स तभी निकाल देने का. विच ग्लैंड इज प्रिजर्व? इंफीरियर पैराथायरॉइड, इट इज अवे फ्रॉम द रिकरेंट लैरिंजियल नर्व. एंड ऑलवेज रिमेंबर दैट बायोप्सी द ग्लैंड टू कंफर्म, जो ग्लैंड रखने वाले हो उसका एक छोटा बायोप्सी ले लो, जस्ट टू मेक श्योर दैट इट इज नॉट अ मैलिग्नेंसी और इट इज माइट नॉट अ हाइपरप्लेजिया. और ऑटो ट्रांसप्लांट माइट बी डन इन द ब्रैकियोरेडियालिस मसल, एंड व्हेन दैट ग्लैंड इज गोइंग टू स्टार्ट हाइपर फंक्शनिंग, यू कैन टेक द ब्लड सैंपल फ्रॉम दैट वेन एंड फ्रॉम द लेफ्ट ब्रेकियोसेफेलिक वेन एंड यू कैन कंपेयर. एंड उनका रेशियो अगर मोर देन 20:1 है, इट मीन्स दैट ग्लैंड हैज गॉन into hyperparathyroid recurrence, and that test is called as Casanova's test. That test is called as Casanova's test. So what is Casanova's test? Whenever you are going to do a 3.5 parathyroidectomy of a patient in a secondary hyperparathyroidism due to renal failure, you are going to implant that gland into the brachioradialis muscle. So brachioradialis muscle mein, why do you implant the gland? The most important thing is you can take the venous sample from that hand itself and you can compare it with the normal hand. So whenever the patient is going to have recurrent symptoms of hyperparathyroidism, you can compare the right hand's brachioradialis muscle, right hand's what you can say venous sample with the left hand's venous sample, and that time if the right hand sample where the gland is implanted in the brachioradialis muscle, that sample has PTH levels more than 20 times that of the left hand, it means that there is the recurrence of the disease, and that is called as a Casanova's test. Important MCQ, important one-liner, important short note. So what is Casanova's test? You have to explain about the secondary hyperparathyroidism, the management of it, 3.5 glands removal, and reimplantation. Where do we reimplant it and how are we going to monitor the patient? Very much important for you to know. What is calciphylaxis? So mechanism is elevated calcium plus phosphate product reduced in the ferritin levels. It is going to be reduced in the ferritin levels, and it is going to cause vascular calcifications, painful skin necrosis, livido reticularis, and gangrenous wounds over thigh and buttocks. So whenever a patient is going to come with sudden onset gangrenous wounds, the patient might not have the gangrene of the distal limb, only the beach इधर से ही बस इतना ही पैच पेशेंट का गैंग्रीनस है, बाकी सब अच्छा है. तो it means that it is not a vascular lesion, it is because of the calcium depositing into the skin. Management is urgent parathyroidectomy plus wound care. So always and always when the patients are going to come to you, firstly you are going to rule out the patient's calcium levels. If it is going to be normal, then you might think of some infective cause. So this is very much important, keep that in mind. सोडियम थायोसल्फेट अगर दोगे तो इट इज गोइंग टू चिलेट द कैल्शियम, बट इट इज ओनली एज एन एडजॉइंट, इट इज नॉट द डेफिनेटिव मैनेजमेंट. एंड पुअर प्रोग्नोसिस इफ सेप्सिस इज देयर. सो व्हेनेवर देयर इज गोइंग टू बी द गैंग्रीन एंड देयर इज गोइंग टू बी सुपर एडेड सेप्सिस, द पेशेंट माइट लैंड अप इनटू फुल ब्लोन व्हाट यू कैन से फुल ब्लोन सेप्टिसीमिया एंड पेशेंट माइट गो इनटू द डेथ. So what is tertiary hyperparathyroidism? Tertiary hyperparathyroidism is nothing but autonomous PTH nodules are started to secrete without after the underlying cause. So renal failure भी correct कर लिया मैंने, फिर भी gland is secreting more amount of PTH even after renal transplant. Mechanism is prolonged secondary PTH. It is going to cause monoclonal nodular gland transformation. So the gland is going to start hyperfunctioning and autonomous secretion उसका PTH का चालू होगा despite the calcium being normal. So features are hypercalcemia. So सेकेंडरी में क्या होने वाला है? सेकेंडरी में इट इज गोइंग टू बी हाइपोकैल्सीमिया ऑलवेज, बट द ग्लैंड स्टार्टेड टू हाइपर फंक्शन, तो बोन्स और डिस्ट्रक्ट करेगा और स्टिल इट इज गोइंग टू कॉज हाइपरकैल्सीमिया. तो सेकेंडरी में ग्लैंड नॉर्मल है, इसलिए द ग्लैंड इज ट्राइंग टू करेक्ट द लेवल्स ऑफ कैल्शियम, बट व्हेन द ग्लैंड इज गोइंग टू ऑटो फंक्शन, इट इज गोइंग टू डिस्ट्रक्ट ऑल द बोन्स. So it is going to be tertiary, where the calcium levels are also going to rise. So patient might have normocalcemia or even hypocalcemia. Treatment is surgery always. So whenever it is a tertiary, whenever it is going to be a tertiary hyperparathyroidism, always 3.5 gland surgery. तो प्राइमरी में भी मैंने देखा, प्राइमरी में एडिनोमा है तो एक्सरसाइज करो. सेकेंडरी में we have seen that first give the medical management, correct the underlying cause, but calcium into phosphate ratio, if it is going to be more than 55, it is going to cause calciphylaxis and hence you should go for surgery. Then we saw the third thing, which is tertiary hyperparathyroidism. Whenever there is going to be a tertiary hyperparathyroidism, you should always go for 3.5 gland surgery. I hope it is very much clear to you. If you are going to go for all 4 glands excision, replant them in the brachioradius muscle. If you are going to keep the gland inside the neck, get a stitch and keep it inside, so that next time you are going to explore, you are going to see it. कौन सा gland रखना है? Always and always inferior parathyroid gland. Always and always inferior parathyroid gland. So MEN1 syndrome, meningine, parathyroid multiplant hyperplasia, pituitary adenoma which is a prolactinoma, and pancreatic insulinoma. So ये सब MEN1 syndrome है. 3 P's are important: parathyroid, pituitary and pancreas. MEN2A is the Sippel syndrome. So it is because of the RET proto-oncogene. Medullary carcinoma of thyroid 100% लोगों में दिखता है. MEN2B में अगर देखोगे तो मेडुलरी कार्सिनोमा दिखता है. इट इज द मोस्ट एग्रेसिव वेरिएंट. सो विद इन 6 months of the birth of the child, you are going to go for a total thyroidectomy. Here you can wait till 5 years. So you can wait till 5 years for a total thyroidectomy. We have already seen in the thyroid pheochromocytoma, hyperparathyroidism 20 to 30% patients, and cutaneous lichen amyloidosis. MEN2B में क्या हुआ? MEN2B में अगर तुमने देखा तो MEN2B में there is going to be going of hyperparathyroidism. तो hyperparathyroidism में MEN2 नहीं आएगा. So it might be pheochromocytoma, morphonoid habemus, mucosal neuromas, intestinal ganglioneuromas. So there is no hyperparathyroidism in the MEN2B syndrome. But here it is very much important to know that it is going to be associated with medullary carcinoma of thyroid. Other familial hyperparathyroid syndromes. So what is the another important syndrome? So it is a hyperthyroidism-jaw tumor syndrome. One thing to important to know, it is going to cause the parathyroid carcinoma. So carcinoma के associated एक ही syndrome का नाम याद रखने का, parathyroid jaw syndrome. So parathyroid jaw tumor syndrome, there might be some mutations, and it can also cause parathyroid carcinoma with some underlying osteomas of the bone. So ossifying fibromas and high risk of parathyroid carcinoma. The jaws are going to have ossifying fibromas or osteomas, and the parathyroid is going to have cancer. Familial isolated hyperparathyroidism. So it might be seen just with MEN syndrome, or it might be seen with multi-gland disease. And familial hypocalciuric hypercalcemia, the calcium sensing receptor का जो problem है, it is a medical disease and no surgery needed. So we have already seen about this disease, and how are you going to check for it? Whenever the ratio is going to be less than 0.1, you are going to go for it. You are going to go for it. So calcium excretion ही कम है किडनी से, इसका मतलब है किडनी में वो रिसेप्टर्स का प्रॉब्लम है. The kidney is not excreting the calcium, and that is the reason the patient is having hypercalcemia. So very much important. So what is parathyroid carcinoma? So it is very rare, but vast majority are associated with hyperparathyroid-jaw syndrome, severely elevated calcium and palpable neck mass. Normally parathyroid adenoma mein neck mass is not palpable, but whenever it is a palpable neck mass, consider it that carcinoma, that the patient might have carcinoma. Management is en-bloc radical excision with the ipsilateral thyroid lobe. अब तक मैंने बोला था बस parathyroid glands को निकालो, but now I am telling you that you have to go for ipsilateral thyroid lobe dissection as well. एंड देयर इज नो सेफ प्लेन, ऐसे कुछ नहीं कि प्लेन में सर्जरी करना है, जितना रेडिकल इन्वॉल्व है सब निकालना होता है. एंड नो रोल ऑफ कीमोथेरेपी हियर. अगेन वी हैव टॉक्ड अबाउट कीमोथेरेपी इन थायराइड मैलिग्नेंसी ओनली एंड ओनली वेयर टॉक्ड अबाउट कीमोथेरेपी व्हेन वी वर टॉकिंग अबाउट एनाप्लास्टिक कैंसर, पुअर प्रोग्नोसिस कैंसर. बट there is no role, there is no absolute no role for chemotherapy in the parathyroid malignancy. External beam radiation might be given, but it has a palliative role, it has not a curative intent. And most common cause of death is hypercalcemia. We saw that arrhythmias ho sakte hai, and it is not because of the tumor bulk. So it is not going to invade any lesion in the carotid, or it is not going to compress the trachea, it is not going to cause lymph nodes erosion, anything. It is going to, the patient is going to die because of the complication of hypercalcemia. So I hope it is clear. Parafibromin जो protein है, it is a good prognostic marker. Loss of parafibromin suggests that the patient is having carcinoma because the differentiation is going to be lost. PGP, it is a P glycoprotein. If it is negative, the malignancy is excluded. So basically two proteins है, PGP and parafibromin. So ये अगर दो secrete कर रहा है ट्यूमर, it means that it is a mature gland tumor and it is not a malignancy. So sign of maturity means these two. जैसे लड़का मैच्योर हो गया, अरे उसको तो मूंछ आ गई, दाढ़ी आ गई, तो लड़का बड़ा हो रहा है, मैच्योर हो रहा है. So similarly, whenever the gland is going to secrete PGP and parafibromin, it means that these are the good prognostic markers and the gland is less likely to have a malignancy. And parathyroidomatosis, diffuse neck and mediastinal parathyroid tissue. Whenever you are going to rupture the tumor while you are going to go for surgery, then that is going to cause seeding, and here again radical surgery is required. And here अगर वो gland अगर गलती से you are going to rupture the gland, there is going to be multiple seeding. That time you might have to sacrifice the recurrent laryngeal nerve. And recurrent disease, it is a dreadful complication, so reoperation is always challenging. So any neck surgery, always remember, any neck surgery you are doing, you have to do it in the form that you are going to do it once and for all. बाद neck exploration करना, जैसे abdomen में एक बार खोला बंद किया, वापस खोला बंद किया, it is not the thing for the neck. So neck, operate it once, but do it very meticulously unless and until the pathology recurs somewhere else. So you are operating a thyroid, the pathology might recur somewhere near the carotids, that is fine, but don't try to go for same surgery multiple times. You are not going to get the same plane and you are going to land up into trouble, because neck is very vascular, very innervating structure, so it is very important for you to go in a proper dissection planes and in proper surgical technique. So I hope it is very much clear. I hope it is very much clear. So just a small recap while we are going. So whenever you are going to suspect a primary hyperparathyroidism, you are going to go for, if there is going to be adenoma, you are going to go for excision. Whenever there is going to be hyperplasia, whenever there is going to be hyperplasia, you are going to go for 3.5 gland excision. सर कौन सा ग्लैंड रखने का? ऑलवेज कीप inferior parathyroid because it is going to be away from the recurrent laryngeal nerve. Superior parathyroids are very close to the recurrent laryngeal nerve and never preserve the superior parathyroid glands. Always अगर preserve करने का time आ ही गया तो you are going to preserve the inferior parathyroid glands. So whenever it is going to be a secondary hyperparathyroidism, whenever there is going to be a secondary hyperparathyroidism, it is most commonly going to be because of the CKD. Here there is going to be, always remember, the most important thing is going to be hypocalcemia. Here there is going to be hypercalcemia. Here there is going to be hypocalcemia, and management is going to be manage the CKD. अगर वो करने के बाद phosphate binders के बाद फिर भी अगर पेशेंट इंप्रूव नहीं हो रहा है, so then you can consider the patient for surgery, but surgery is not the first resort here. And why is the phosphate important? Phosphate is going to stimulate FGF23. We have seen FGF23. It is going to inhibit the calcium. It is going to inhibit the calcium. Hence the patient is going to have reduced calcium levels, which is going to in turn secrete the PTH. So PTH is going to be secreted because of the low calcium levels, because there is going to be raised FGF23, because of more phosphate. And third important thing is the tertiary hyperparathyroidism. Tertiary hyperparathyroidism मध्ये क्या करना है? Tertiary hyperparathyroidism मध्ये always you are going to go for surgery, 3.5 gland excision, and half gland you are going to place in the brachioradialis muscle, because you are going to go for recurrent monitoring from the vein, and that test is going to be called as Casanova's test. And we saw the ratio of 20:1. So 20:1 ratio, whenever there is going to be 20:1 ratio of brachiocephalic vein from the hand having the parathyroid, and from the other hand if it is more than 20:1, it means that it is the recurrence of the disease. So it is very much important. And when you are going to talk about parathyroid carcinoma, it is going to be very rare, but it is going to be associated with two proteins. What are the two proteins associated? It is going to be associated with, yes, we saw the two proteins name. It is going to be parafibromin. It is going to be parafibromin, and the other protein is going to be P-glycopeptide. P-glycoprotein, sorry. So whenever these two things are going to be present, it indicates a good prognosis because the cells are going to be mature. But if these cells are going to be absent, it means that the gland is undifferentiated, and here you are going to go for what is called as a radical surgery. And here there is going to be risk of tumor spillage. And here you might need to compromise the recurrent laryngeal nerve. We have seen everything in detail. This small flowchart is telling about everything. I am sorry about my presentation, but this small flowchart is going to talk everything of what we have discussed in last 1 hour. So I hope it is clear and you have enjoyed the lecture. We'll meet tomorrow and we'll start off with breast tomorrow, or maybe with the endocrinology. So I'll check the sequence tomorrow and we'll confirm it tomorrow. So thanks for attending the lecture. Till then, take care, bye bye and good night.